Good evening, everybody. My name is Dr. Matthew Holder, and I am the President-elect of the American Academy of Developmental Medicine and Dentistry. I am your host tonight for the Physician Education and Developmental Disabilities webinar series, sponsored by the Florida Developmental Disabilities Council and presented in partnership with the Florida Center for Inclusive Communities. Tonight is the first installment of our 12-part series. Before we get started, I would like to make a few announcements about this series. Please note that we will be holding a new installment of this series every Tuesday night at 6 p.m. Eastern Time until October 9th. Within 1 week of the live event, we will post the video recording of each of these webinars online at www.aadmd.org. You and your colleagues will be able to view these recordings online and receive CME credit for the next 2 years. So don't worry if you miss one of these live events. Each of the 12 parts of this series is accredited by the American Academy of Family Physicians for 1.0 credit hours of AAFP prescribed credit. This is recognized by the AMA as equivalent to 1.0 hours of AMA Category 1 credit. In order to obtain your CME certificate for each webinar, you will need to log on to the link that we will provide for you at the end of the webinar. This link will also be available at the AADMD website after this webinar. Once you log on to that link, you will need to complete a short survey about the webinar, and you'll need to receive a 7 out of 10 score on the quiz, so make sure that you pay attention. The process is automatic, so once you complete the survey and pass the quiz, you'll be able to print your certificate. For those of you who are not physicians, you may also use this link to obtain a certificate of completion. The process is the same, just keep in mind that we are only able to award continuing medical education credit for this webinar series. The PEDD webinar series was designed to provide an introduction to the concepts of the field of developmental medicine to residents in primary care specialties. However, because we know that so few physicians have received formal education in caring for adults with developmental disabilities, we know that it will be of value to practicing physicians and, frankly, a whole host of other healthcare providers as well. We are following a sort of biopsychosocial model with this curriculum. Some parts of the series will be more focused on medical science, some will be more focused on psychological or sociological factors, but all of these are important areas of focus when caring for people with intellectual and developmental disabilities. Please note that we are scheduled for 1 hour of webinar time tonight. If you would like to ask a question, please type it in the question box of your control panel. We will try to get through as many questions as possible during the time we have left at the end of the presentation. Tonight we're going to be kicking off the webinar series with a spectacular introduction to the history and terminology of this field that any clinician, well, anybody should know when they begin to work with people with developmental disabilities. Our speakers tonight are two trench warriors who have both done a lot at the national level and who are, of course, very well known in their home state of Florida. They are Dr. Liz Perkins and Dr. Lori Woodard. Dr. Elizabeth Perkins is a research assistant professor and health coordinator at the Florida Center for Inclusive Communities at the University of South Florida. Dr. Perkins has a PhD in aging studies and a BA in psychology, both from USF. She is originally from the United Kingdom, where she is an RNMH, a registered nurse from the United Kingdom trained specifically in the field of intellectual and developmental disabilities. She is an expert on aging people with intellectual disabilities and their caregiver issues. Dr. Perkins' work has been published in a variety of journals, including JAMA, Academic Medicine, Clinical Gerontologist, and the Journal of Policy and Practice in Intellectual Disabilities. Dr. Perkins currently serves on the board of directors of the American Association on Intellectual and Developmental Disabilities. Part of her role with the FCIC is to educate health professionals regarding people with disabilities. Dr. Lori Woodard is an associate professor of family medicine at the Morsani College of Medicine at the University of South Florida. She is a member of the Florida Academy of Physicians and of the American Academy of Developmental Medicine and Dentistry. Since 2005, she helped develop and continues to lead a 3-week module clerkship. Based on this module in 2011, she was awarded the inaugural Morsani College of Medicine's Innovation in Teaching Award. She is the immediate past chair of the Group on Disabilities in the Society of Family Medicine, a founding board member of the Alliance for Disabilities in Health Education, and a participant in the National Curriculum Initiative in Developmental Medicine. Other activities include membership in Florida Transition Program for Youth with Special Needs, as well as a community board member in the Florida Center for Inclusive Communities, a university center for excellence in developmental disabilities. In addition to her teaching and community activities, Dr. Woodard is a busy practicing physician whose panel includes several patients with disabilities. So without further ado, I would like to turn this presentation over to Dr. Elizabeth Perkins. Liz?
It's my honor to start the webinar today, and I did want to refer to a very powerful consensus statement that the American Academy on Developmental Medicine and Dentistry released regarding health disparities, particularly with people with intellectual and developmental disabilities, and why there's a real importance to cover this subject for physicians, primarily, as I've highlighted here. The issue is a lack of exposure and a lack of training that physicians have not had of people with intellectual developmental disabilities, both in their training and in their actual practice, because of the fact that there might not be so many individuals with disabilities that they see on a regular basis. So our goal here is to sort of help make the unfamiliar become familiar for physicians, and we really want to applaud everybody that signed up for this webinar, and hopefully they will stick with the whole 12, and to get a really good introduction and in-depth knowledge of people with developmental disabilities. And as such, this opening webinar is, we are covering a lot of variety of topics just to sort of give a bit of a background, especially for individuals, for physicians who are not well orientated to the issues with in developmental disabilities and the disability field in general. So that's really where we're coming from in terms of what we're hoping to do for you today. I do want to start off to say that I'm really passionate about this field, so I'm so glad that you're taking the time and the opportunity to become acquainted and to find out more information. And what I love about it is there is incredible diversity in this field. It's incredibly interesting. And just to sort of highlight a few really diverse individuals with developmental disabilities, to the top left here is Kim Peek. Anybody who's familiar with the film Rain Man will know that this individual is actually the person that Rain Man, who's played by Dustin Hoffman, is based upon. Next to him is Josh Blue. He's actually a comedian with cerebral palsy, and actually his humor is based very much on his cerebral palsy. He makes it the vehicle for his comedy, and is a really interesting and extremely funny gentleman. To the right is Temple Grandin. Temple Grandin is probably one of the most famous people alive today with autism. She's done a great deal in raising awareness because she's very articulate. She has a PhD in animal sciences and is an associate professor in animal sciences at Colorado State University. And she really is a very interesting person because she's really wrote a lot of books, and actually had a film, a biopic made of her called Temple Grandin, and to describe how she experienced the autism and the sensory issues that she's had with having autism spectrum disorders. Bottom left there is Gloria Lenhoff. She is a lady with Williams syndrome. She has an IQ of 55, so you'll be very interested to know that she actually sings in 30 different languages, and is incredibly well known for her wonderful soprano voice. The gentleman in the middle there is Bert Holbrook. He was 83 with Down syndrome when he died earlier this year, and held the Guinness World Record for the oldest gentleman alive with Down syndrome. He's actually from Minnesota, and that record in the ladies is held by Joyce Greenman in England, and she's actually 87. And to the bottom right there is an individual participating in Special Olympics, just to say it's not bowling anymore. So let's move on. Do want to highlight the fact that the CDC is really paying particular attention to the field of intellectual disabilities, and I will describe in depth what that is about in terms of the different definitions. Just to highlight the fact that as recent as 2009, we have the CDC released this white paper to highlight the fact that people with intellectual disabilities do have a lot of vulnerable issues in terms of health access, health prevention, missing cancer screenings, poorly managed chronic conditions. We have issues with high levels of obesity, undetected poor vision, and mental health problems. And so, yes, they can have a lot of medical complexities, but some of these are very easy fixes with just a little bit more attention given to their particular needs. Whoops, I'm going the wrong way there. One of the, in terms of the power of language, and particularly in this field, what we really need to be aware of is having people-first language. Language is extremely powerful, and for a person with a disability, we really want the disability to be secondary, the condition to be secondary, or the particular disorder to be secondary. So we have things such as avoiding the disabled or group terms and actually say a person with a disability, person who uses a wheelchair, person with autism, person with Down syndrome, typical rather than normal, and person with intellectual disabilities. So disabilities is an attribute, and it should never be the primary description of a person, and that's really very important. And there's a sensitivity to that in the community of individuals with disabilities. And also the use of the word retarded, mental retardation, I would hope from this day forward that you try and strike that from your lexicon if you do use that term. There is a national campaign to stop to use that word, and also Rosa's Law was a federal law signed by President Obama in 2010 to replace all references in federal legislation to intellectual disability rather than mental retardation. So I shy away from using that word going forward in this presentation, but to make you aware of it, and there is a national campaign, and AADMD are fully behind and endorse that campaign. So, moving on to disabilities, it's interesting to note here the term disability as it's defined with the Americans with Disabilities Act, and there's three ways in which an individual is considered to have a disability: the physical or mental impairment that's substantially limiting one or more of life's major activities, a record of having such impairment, or being regarded as having such an impairment. And the ADA was a landmark piece of legislation that basically barred discrimination on the basis of disability in a variety of spheres, including employment, public services, accommodations, telecommunications, and it also required reasonable accommodations and accessibility, which was very important. And it is interesting to note that you will come across individuals for which the term disability, they don't ascribe to that term. It can be quite subjective because if you have an individual that doesn't consider that they have major life activities that have no impact, that they sort of see that disability as being really not a description of them per se. And so sometimes people won't self-report necessarily as having a disability automatically, even if they do have. In terms of the term developmental disability, so disability is a larger umbrella term, and so we're now passing down into smaller and smaller groups of individuals. So developmental disability is a term that refers, and it's a federal definition here, of severe chronic disabilities attributable to mental and or physical impairment manifesting before the age of 22, somewhat arbitrary, and it's tied into access to services, and resulting in substantial limitations in 3 or more areas. And so you'll see those types of areas: language, learning, mobility, self-direction, capacity for independent living, and economic self-sufficiency. And basically, in many individuals with developmental disabilities, there will be some continuous need for an individually planned and coordinated system of services. In Florida, the Agency for Persons with Disabilities is the agency that has this particular definition. And it does categorize developmental disabilities in terms of eligibility for services as having a disorder or syndrome attributable to, and yes, Florida still uses that term, unfortunately. I will call it intellectual disability, cerebral palsy, autism, spina bifida, Down syndrome, or Prader-Willi syndrome, manifesting before the age of 18, and constitutes a substantial handicap that can be reasonably expected to continue indefinitely. And so overall, the population prevalence of individuals with disabilities is around about 15%. And here you have a list of intellectual disability, cerebral palsy, autism spectrum disorders, and so on. And those are the sort of the major developmental disabilities that we do have. And it's important to note, and the next slide here, and I really want you to sort of just focus on the far right two columns, the 2006 and 2008, where we have, I don't know whether this shows up on your screen, I hope it does with my arrow, but if not, basically we're looking at that figure of developmental disability running at 15% in 2006 and 2008. And you'll see the ones that I listed previously, those types of different developmental disabilities are all here. I did want to just point out that you will see the quite dramatic percentage change with regards to autism. And one of the things that's been very noticeable in the field of autism is the rise in apparent prevalence. And most of that, I think, can be very much attributed to better diagnostics, better recognition, and better diagnosis of individuals with autism. And that's very important to note there, but also to note that autism, compared with other forms of developmental disability, that there are a lot of different types of developmental disability, and so hence there is a lot of diversity, although a lot of research dollars and attention of early intervention, particularly of autism, has been, especially in more recent years, attributable to the fact that a lot more children are diagnosed at a much younger, early age, and very important to have that early intervention. So we go from disability to developmental disability now into intellectual disability. So intellectual disability, by very definition, is a developmental disability, but it speaks specifically to those that have significant limitations in intellectual functioning. And the AAIDD, which is the American Association of Intellectual and Developmental Disability, they categorize intellectual disability as being sort of having two major issues, having limitation in intellectual functioning, but also adaptive behavior, and again, a disability that originates before the age of 18. And also, in consideration of intellectual disability, one needs to really consider the community and the environment typical of an individual's peers and culture, their linguistic diversity, and cultural differences. And so in the scheme of things, an IQ testing, we normally know, is an individual that operates in a 2 standard deviations or below the population mean. So normally a test score, an IQ below 70 or 75, depending on what is used in terms of the particular IQ screening. And then the other section of intellectual disability is that notion of adaptive behaviours and how one can perform self-help tasks and activities of daily living to direct their own life. So issues are important, such as conceptual skills, basically the language and literacy, having number concepts, social skills, how a person interacts with other individuals and have social problem-solving skills, and whether they have any issues with being naive or being more likely to be victimized because of the naivety and things of that nature. And practical skills, those are the activities of daily living which are very important for us to be aware of, and obviously to have a good quality of life, and so that a whole range of skills that encompasses for both you or I or any individual in terms of being able to function in our daily settings, in how we interact with the world around us. So in getting a diagnosis of intellectual disability, really the core issue of when one has a diagnosis really is to help the classifying and evaluating individuals really to tailor support to enable them to function well within their environment and to maximise their health, self-help skills and things of that nature. And when we talk about intellectual disability, we generally have 4 categories. We have mild, moderate, severe, profound levels of intellectual disability. And we think now in terms of support that is required for people with intellectual disability. And so people in the mild range, and that's about 85% of all individuals with an intellectual disability will fall into that category. And we have about 10% fall in the moderate, about 3% in the severe, and 2% in the profound. So most individuals fall in that mild category, and just to sort of equate it, the American Psychiatric Association compares mild intellectual disability to operating around the level of a 6th grader, whereas a moderate is around a 2nd grader. Second grade ability, and then with more severe and profound levels of intellectual disability, there is normally an increase in medical complexity, so they have more issues with sensory deficits that might occur. You might have problems with maintaining one's self-care, so you have individuals with severe and profound moderate levels of intellectual disability that have need of having people to provide for hydration, for nutrition, help with elimination and things of that nature. So the more profoundly the level of intellectual disability is often categorized by having those increased levels of medical complexity. And I do want to, because a lot of people learn about developmental disabilities in the sphere of pediatrics, and just to highlight the fact that people with intellectual disability are having a much greater life expectancies than ever before, and certainly in the last 30, 40 years there's been a tremendous increase. Such that people with mild intellectual disabilities are basically akin to another minority category in the United States of Black Americans, and then will have their life expectancy a little lower than white Americans, which is about 78. Black Americans have a life expectancy around about 74, so people with mild intellectual disability are actually the same life expectancy as some of the minority groups. But even, please do note, moderate and severe profound levels of intellectual disability, we have individuals now living into their 50% basically of a cohort now of people who are born with severe and profound intellectual disabilities are very much needing to have provision of care across the lifespan. I do want to talk a little bit about brief historical retrospectives of the treatment sections of people with disability. It is important that there has been very much an ambivalent attitude throughout history, ranging from pity and ridicule, in some cases actually being individuals with epilepsy many years ago were unfortunately thought to be possessed by the devil, and so there's been a very good and bad perspectives about people with with disabilities. And then there was a rise of state institutions that occurred, and this was really done for beneficial and benevolent reasons, I should say, and to provide for the sick, the needy, the poor, and individuals with developmental disabilities often came into that category. There was also a rise in the people to provide residential schooling of people who are blind or people who are deaf, and that was sort of also akin to a rising in the state institutions. Unfortunately, what happened, these institutions started to become very overcrowded, and economics being what they are, sometimes individuals were placed into their situation. Families asked for people to be institutionalized because they were more of a drain on the family's resources. And also segregation and the eugenics movement came along which was very obviously very unfortunate, and also at its most extreme point was the role of the Nazis, you know, where there was thousands of individuals with disabilities that were killed as part of the Holocaust. And a lot of this was because of the segregation. You know, when you have individuals outside of the community, then they become more feared and people aren't familiar with individuals, and so it was sort of a self-fulfilling prophecy, unfortunately. And even in the United States, there's 47,000 sterilizations of people with intellectual disabilities occurred in 30 states, because it was certainly back then thought that individuals with disabilities, intellectual disabilities in particular, shouldn't be allowed to have children. And it might surprise you to know there's about 40,000 individuals with intellectual disabilities in the United States today who are parents, and they're parents with intellectual disabilities. And unfortunately, in a lot of these different institutions, a lot went on behind the doors that was unethical, and also, you know, for people that didn't have a voice or didn't have advocates to defend their rights. So you had things such as the scandals about ingesting of radioactive foods and hepatitis B transmission experiments that went on, that prompted the establishment of institutional review boards and ethical research conduct. And obviously, people with intellectual disabilities are noted to be a vulnerable population for research, and actually have to have more protections now, not less. You know, and basically came as a direct result of some of the scandals from these types of experiments that were done for individuals that didn't have a voice. And some of the major legislative turning points, just wanted to sort of highlight. President Kennedy's panel on intellectual disabilities, I will call it, did set into place a sort of an explosion in terms of having expansion of community services, scientific research about the etiology and prevention. That's actually the creation of the USEDS. Was part of that a recommendation from that panel that was came about in 1963, those University Centres of Excellence in Developmental Disabilities, and comprehensive plans to improve residential and community services. The next thing that came along was 1971, which was basically the federal initiative to have decrease the size of these institutions, and so a lot of these intermediate care facilities were sprung up because there was a lot of funding available, but the funding was contingent on having smaller numbers and better size and better treatment plans for people with intellectual disability. 1973, there was a Vocational Rehabilitation Act, and that forbade discrimination in any program that was funded by the federal government, or any programs receiving federal assistance on the basis of people or employers having a disability. Education, it might surprise you to learn that it wasn't until 1975 that all individuals, all children, irrespective of their disabilities, were then mandated to have some form of education. Prior to that, it was some institutions would provide it, some wouldn't. And in 1981, again, realizing that we need to do more to promote a more community-based, and again, from the intermediate care facilities to reduce the sizes of those, we went to the Medicare Home and Community-Based Waiver Services and the Katie Beckett waiver, and that was to encourage and allow for individuals to receive services outside of institutions in the communities. We already mentioned about the Americans with Disabilities Act, and that was an overarching legislation that really sort of set the tone about equality for people with disabilities, and that's been sort of followed. It's been the model that's been followed by other nations since then. And then the Olmsted decision basically was a decision by the Supreme Court to ensure that basically to uphold the fact that institutionalization severely limits a person's ability to interact with family and friends. And if the person is institutionalized, it must be because, well, they can, in terms of having those types of facilities available, it makes it a discrimination basis for a person with a disability to be able to live where they want in the community. So I'm just quickly going to sort of talk a little bit about the community integration and guiding philosophies. Normalization, social role valorization, and the process of deinstitutionalization. They were very much in concert with those legislation and those changes. And normalization basically means just to have a normal life, to have the choices that you or I take for granted. Social role valorization was the concept of, well, it's not just enough to have a normal life and to live in the community. For a person to be respected, there needs to be a social role and a social interaction with their ongoing community. And so again, that sort of helped to stem the institutionalization from a philosophical point of view. And then we've had person-centered planning, because obviously in years gone by, we had situations where a lot of decisions were made about a person without ever involving the person themselves. And nowadays, we look very much more into self-determination, advocacy, self-advocacy and inclusion. Those are the real philosophical guiding points. And so you'll see some of those question pictures below. Left is from an institution that would, again, share your home with 5,000 people. If you were a child back in the 60s, you share your bedroom with 99 other people. It wasn't a normal life. And so, again, we sort of thankfully have moved very much far from that. So guiding philosophies, quality of life, choice, risk, dignity and respect, these are fundamental rights and they're extremely important to uphold for individuals with disabilities. I really want to make the point about risk and having the chance of learning from failure rather than denying the chance to learn. Often we can be a little bit overprotective, and I would suggest to you that some of the ways that you've learned best is when you've made a mistake and you think, well, I'm not going to do that again. And so that's really important to consider. And also, I do want to make the point about there's no place for pity in this particular situation for people with intellectual developmental disabilities, because pity is derived from a judgment of unfavourable comparison to one's own circumstances. Employment, I just want to make the point that this is a real area now that we're seeing more and more. We've seen a lot of changes in the way that education and inclusive education, and so it seems natural now that the sort of the vanguard of the new area that we're really trying to make a big difference is in the area of employment. Because there is a situation where a lot of adults with disabilities are underemployed or unemployed. And so these are some of the benefits from having employment in the community. And as you say, it's not just a case of, you know, we all want to have employment, we all want to be a part and contribute, we all want to earn a wage, but also the knock-on effects of that by having working towards employment and having increases in independent living skills and quality of life and self-advocacy. So inclusion now, as you see, it's not just a case of where we live, it's being a part of the community, it's representative of the community in all areas, be that recreation, be that vocational, be that employment, be that education. And it's to be able to participate in life's community as a fully respected member of that community. People with intellectual disabilities, I want to just quickly point out the fact that only 12% live in a residential facility nowadays. Overwhelmingly, be that with a family caregiver or in their own household or with the spouse. They live in a situation that's in a family environment or supported living or independent living. Only 12% live in what we consider a supervised residential facility. And so if you look at the column to the right, the supervised residential facility, those are different areas, and overwhelmingly 70% of all the people that live in a residential setting live in a situation with 6 or less other residents. And so a very big difference in terms of where people live nowadays compared to 50 years ago. So here's just a little reminder. This is a state institution, and these are 4 group homes in a local, it's actually U Park in Pinellas County, examples of group homes where individuals with intellectual disabilities live. And so you see there's a very big change there. And I'm just going to end by talking a little bit, very briefly, about applied behavior analysis, just because as a physician who might come across an individual with an intellectual developmental disability, sometimes they might need behavior therapy, and it can be used for a variety of different aspects, not just challenging behaviors, but learning skills. And so behavior therapy traditionally used both positive and negative reinforcers, and aversives and punishment, which can be pleasant and not painful. And it uses now the science of applied behavior analysis, and really what that is to fundamentally to try and do is to determine the ABCs, what happens directly before the behavior, what's the behavior itself, and what are the consequences. And nowadays we have what we call positive behavior support, and that basically prohibits the use of aversives or punishments, promotes positive behavior by changes to the environment, appropriate skills, and rewarding of appropriate behavior. So that was my very quick run through of the history of and some of the terminology, and I'm now going to hand over to my esteemed colleague, Dr. Laurie Woodard.
Well, thank you so much, Dr. Perkins. That was just a really excellent, chock full of information review. And I'm speaking to those of you out there who are practicing clinicians and saying to yourselves, well, this is all fine and good, but how does it affect me? And I'm saying to you, I'm a doctor who sees patients every day, patients with disabilities, and what does this information mean to me? I think first and foremost, I don't think we can overstate the power of language. I'm sure that you, like I, have seen in charts, or maybe even used yourself the term, the patient is wheelchair bound, the patient is wheelchair confined, the patient suffers from cerebral palsy or is afflicted by Down syndrome. What we may not realize is that when we use these terms in our speech and in our charting, this really reinforces demeaning stereotypes of incapacity, which is not only difficult for our patients, but as we utter them, our words, being physicians, our words really do carry extra authority, and we end up convincing ourselves that these are people of whom we have fairly low expectations, and ultimately when this happens, we can't imagine quality of life that may then affect our medical care of these folks. I would say to you right now, close your eyes and just conjure up an image. If I say to you the patient is a wheelchair user versus the patient is wheelchair bound, and I would say you would probably see in the former case a more empowered individual that you would expect to have more self-efficacy. I think we also have to understand that when our patients come into the room, our patients who have been around for a while have maybe some mistrust. As Dr. Perkins has pointed out, the doctors have sometimes been the problem rather than the solution. And we have to understand that some of our behavior in the past has been dehumanizing, and not all of our patients are ready to jump aboard what we have to offer for them. Language is also important. because some of the terms that we use, such as impairment, disability, and handicap, we use fairly casually, and yet they may have they do have definitions that we as practicing physicians may not be fully aware of. So to review that just briefly, impairment refers to a loss or abnormality really at the anatomical level of tissue level, organ-based level, whereas when we're talking about disability, we're talking about the person as a whole and how the impairment affects the functional performance. Handicap is a term that really refers to a disadvantage for a given individual in a given situation. And in certain contexts, a person with a certain disability might have a handicap. In another situation, they may not be handicapped. This terminology helps us to understand the way disability impacts patients both at the level of organ system function as well as the person's ability to function in society. And the way we view disability kind of varies according to who we are. I bet for most of us, we're most comfortable in what we would call the medical approach to understanding disability. And I know when I see a patient, I'm most comfortable if I can make a diagnosis and then try to come up with a treatment. When the patient's in the room, that's what I'm thinking about. When we approach disability from purely a medical model, we tend to see that disability as a problem with the patient, a problem that we need to fix. And that's when we get pretty frustrated because a lot of times these patients have problems that we just can't fix. The social model, on the other hand, is a model that's held by many in the disability community who say the problem really isn't the individual, the problem is the environment and society in which the person lives. And therefore, the problem is, the solution rather, is really fixing the environment, not fixing the person. In fact, probably the most productive way of approaching disability is a combination of both the medical and social models into a more of the biopsychosocial model, to understand that in a given person, sometimes the issue is related to what's going on internally with the patient themselves, but many times it's that interaction between the patient and their environment which creates the health situation. Which brings us to a very important caveat, which is simply something that I think is an important thing that we as physicians just have to keep in mind. When we have a patient, when we care for a patient with a disability, this does not necessarily mean that the patient is sick. Disability is not the same as illness. And that may give us a moment to think a little bit about what is health. I've given you a couple of definitions. One of my colleagues pointed me towards one definition by René Debow, who wrote several years ago, to be healthy does not mean to be free of disease. It means you can function, you can do what you want to do, and become what you want to become. I think if we keep that concept of health in mind, that helps us to be informed in terms of what we can accomplish in terms of caring for our patient. Thus, it reorients us from seeing a patient with a disability as somebody with a chronic disease for whom we can do very little to an individual who is just part of the spectrum of humanity who come through our office every day. Now, in primary care, many of you may be familiar with a framework of approaching patients with chronic conditions called the chronic care model. And certainly the chronic care model is something that we can adapt for caring for our patients with disability. And in the chronic care model, what we are trying to do is transform healthcare from a system that is essentially reactive and responding mainly when a person is sick to one that is proactive and focused on keeping a person as healthy as possible. Certainly that's a parallel goal with our patients with disabilities, and some of the difficulties that we encounter in providing chronic care to our patients, care to our patients with chronic conditions include we're often rushed for time. These are patients who could use more time. There may be established guidelines in terms of caring for these patients. We don't know about them. There is lack of coordination. We may find ourselves repeating and being redundant in some cases, and then there are gaps in our care in other cases. Active follow-up may not occur. And finally, we don't really encourage patients to become involved in managing their own condition. The chronic care model has come up with some remedies which we certainly can apply to our patients with disabilities. And I won't go through all of these, but I think one of the most important one is creating a culture, organization, and mechanism that promotes safe and high-quality care. To do that, we have to make sure that our offices are friendly physically, that they're accessible, and that our attitudes are also promote accessibility. And it's not only our attitude as the doctor or the nurse, but it's everybody in the office has to have the appropriate attitude. And that starts from the top and works its way down, and often the physician or nurse practitioner is the leader of the office, so we set the tone for everybody else. It's also, as you read down, other sorts of ways that we can adapt to improve our care, but it's really being patient-oriented, patient-centered, listening to our patient. I know I have learned so much from my patients, and often the diagnosis is just the tip of the iceberg. Patients with the very same disabilities may have much different health issues, different levels of functioning, and you only know that by listening to your patient. Collaborating with people outside of your discipline is important in terms of achieving health care, and then of course encouraging your patient to become active not only in their care but advocates for their own care. I want to take a moment just to mention sexuality and disability because this is a healthcare concern that is often neglected when we're caring for patients with disabilities. We are going to spend another webinar talking about this in depth, but I want to bring it up today because when we care for people with disabilities, we often forget about this entirely. And another important caveat that we need to keep in mind is that sexuality, which is the desire for a close and intimate relationship with another person, is really a human attribute regardless of the person's ability. And typically, we have difficulty. We ignore sexuality in our patients, and patients with disabilities often report that they feel as if they are asexual. And sometimes we overreact. We fear that our patients may be hypersexual, and this is especially true with patients with intellectual disabilities. Some of the consequences of ignoring this topic is that our patients experience loneliness. They often have limited or wrong information about reproductive health. It leads to disparities in terms of health care and preventive screenings, and it may result in some behavioral challenges with our patients as they try to deal with their thwarted sexual urges. And finally, and perhaps most importantly, this is a population that is really at risk for abuse and exploitation. And by not educating and talking with our patients about sexuality, this is a health issue that may be missed entirely. Okay. Lastly, I would like to just point out that this caring for patients with disabilities often raises some ethical considerations which may give us pause. As Dr. Perkins mentioned, sterilization was one way that in the last century was a very common way that sexuality was dealt with. We'll just eliminate it by sterilizing our patients. But this is not the primary way we want to care for our patients in terms of their reproductive health. And I would certainly point you in the direction of the website from the American College of Obstetrics and Gynecology. They have a very nice presentation which talks about reproductive health for patients with all types of disabilities, including intellectual disabilities. Many of you may be familiar with what became called the Ashley case or the Pillow Angel case. This was a situation in 2006 that was reported in the medical literature but quickly gained footing in public media and was talked about both in the professional literature and in the public media as well. In this case, a family petitioned to have their 6-year-old daughter. They wanted for her health and well-being from their point of view, and she has a very severe intellectual as well as physical disability. They felt it was in her best interest to undergo a sterilization procedure, which consisted of a hysterectomy. They also had her breast buds removed, and she was treated with hormones to slow down and stop her growth to keep her a smaller individual, which would improve their ability to care for her, as well as they felt protect her from discomfort of going through maturation, as well as protect her from abuse or exploitation later. This really set off a lot of discussion both in the disability community and the community at large. And it points out that different people, good people, but people can have very different takes on the same subject. It's very controversial, and I would recommend you to read a little bit about it and think about this to some degree. But the point is that people with intellectual disabilities, as Dr. Perkins said, many of them are parents already, and that they can enter marriages or other kind of close, intimate relationships. There are guidelines to help determine whether these people are safe and appropriate for these kinds of relationships, but we certainly, in today's standards of thinking about patients with disabilities, this is not a part of life experience that we feel should automatically be denied our patients. In summary then, what I've been talking about really is what Dr. Perkins mentioned earlier, is that we as physicians can assist our patients in achieving social role valorization. And that means that by achieving social role valorization, by according these people roles that are respected, they in turn receive dignity and acceptance within the community. So our behavior is really important and for them to achieve this role. And some people also talk about spiritual valorization, and that really refers to those people with very profound disabilities who really have, it really would be very difficult for them to have any typical social role. These are people who need assistance with all aspects of activities of daily living, may not be able to speak, may not even be able to hold their head up. And what we know is that people who have close contact with individuals with this level of disability often find their own sense of humanity and purpose in life has been heightened, has been enriched, and that these people bring joy to them as well. In summary then, we as physicians can either choose to contribute to or to break the stigma cycle. If we can raise our expectations of who our patients are and value our patients more, then they are more likely to enjoy opportunities that might otherwise diminish their quality of life. And that's where I think we're going to leave it at this point, that we're part of the solution these days. We want to be part of the solution, no longer part of the problem. And at this point, we are
Open to questions.
Open to some questions and comments.
Wonderful. Thank you very much, Lori. Thank you, Liz. Can you hear me okay?
Yes, yes. We're glad to hear you.
Great, great. I want to apologize to everybody, and especially you, Lori. Right in the middle of my introduction, we had a little technological sound glitch, but we fixed it, so we're back to normal now. Would you mind putting the up the very final slide in the presentation? I think it has the link that people need to go to for the quizzes at the end. I'm not sure. Is that the last slide?
Yep.
Okay. There it is. There we go. I'll just take this question first, get the housekeeping out of the way. If you want to get your CME certificate, all you have to do is go to this link right here, bity.com/PEDD2012, and that will get you into our system, and basically you'll be asked to sign in and register. Then you complete a survey, take a quiz, and the certificate will be automatically emailed to you. So it's a pretty easy process, and we'll leave that up there. And again, that will also be on the AADMD website. Now, for a few questions, we had a few. One of the questions that was asked was about the term retardation, and if that is going to be changed in the medical diagnostic nomenclature. Would anybody care to comment on that? Maybe if you're familiar with the DSM-5 coming out, or what the AMA has been doing around this?
Well, I know in terms of the DSM-5 that there is some talk of intellectual disability being described as an intellectual disorder, and I know AAIDD have been coming out in opposition of that particular term. And so it is a difficult situation right now in terms of, we're wanting the DSM-5 to actually reflect the term intellectual disability, which is now in use, worldwide basically, and also in federal definitions now to replace with intellectual disability rather than intellectual disorder. And so it's a step backwards, unfortunately, and there's been a lot of public comment about that issue. So in terms of DSM-5, yes, there's work to be done in terms of describing it as a disability rather than a disorder. And part of that issue is that it comes from the Statistical and Manual of Mental Disorders, and so in terms of looking at it purely from a psychiatric point of view, it seems as if it's a fair descriptor, but we do not like the term intellectual disorder, and we're really fighting for the term intellectual disability. So please add your voice to that comment, because it's very important that we try and inform people about that.
Yes, Liz, the AADMD also took the same stand with the AAIDD on that, and we've communicated that with the APA as well. But at least the good news is, they are at least eliminating the word retardation from the nomenclature, which is at least half a step in the right direction. And also right, and also the AMA recently passed a resolution that that I was familiar with, that essentially removed the word retardation from their documents and replaced it with intellectual disability. So we also think that's a good step in the right direction as well. There was another question, and I went ahead and looked up these statistics just so you wouldn't be put on the spot there, Liz and Lori, but we have a question which was, do you know what the prevalence of autism is in Florida? Now, if you already know this, I'm just going to go ahead and say what it is. It's 7.2 per 1,000 children. What that breakdown was, at least in terms of what I was able to find, is 11.3 per 1,000 in boys and 2.9 per 1,000 in girls. Does that sound right to you, Dr. Perkins and Dr. Woodard?
Yeah, I know that, and I think it's sort of very difficult to sort of just highlight Florida as a state on its own, and those figures make up the figures that come from the CDC that combine various states. And I think a good way to consider it is actually overall, because of the numbers involved, you know, the higher amount of population, the more accurate you can get a sense of prevalence figures, which the current number is 1 in 88 for individuals with autism now. So that sort of gives you, you know, fairly concrete figure to work with.
Now there was a couple of related autism questions. One was this person said, I have heard that the increase in the diagnosis of autism has mirrored a decrease in the diagnosis of intellectual disability. Is there some diagnostic substitution going on? I thought that was an interesting question.
I think that's a fair comment. I think that, you know, now that the accuracy in autism diagnosis is increasing, some people might have come under the umbrella term of an intellectual disability in years gone past rather than autism per se. And there is that situation where you do have individuals with autism, about 40% do have an intellectual disability with autism. You have about 10% of individuals with Down syndrome who have autism. You know, it can be co-occurring with other developmental disabilities and etiology. And so it's a case of what comes first, the chicken or the egg, I think, in terms of diagnosis. Dr. Woodard, do you have anything?
Well, I agree, and they're often dual diagnoses. So.
So I have another comment from a mother actually out on the West Coast. I thought this was an interesting comment. And a mother of a child with autism. She said, in my area, people with autism prefer to be called autistic rather than a person with autism. And you know, I'm wondering, is that that person first language? And I've actually heard this traveling around the country in some areas that you know, sometimes the autistic community likes to be called autistic rather than a person with autism. Have you heard that in Florida, or is, any comments on that?
There are some individuals and there are some groups with autism that do prefer to have the term autistic prior to a person. The reason why we like to encourage the people first language, people with autism, people with intellectual disabilities, that it sort of gets into the habit of saying person first. But that's not to say if people express that they prefer to be called, you know, an autistic person, to respect that. But I, for one, would prefer that I on a sort of a general basis, always go with the person first, language first and foremost, until I'm sort of told otherwise, or there's a preference that's indicated otherwise.
Wonderful, thank you. Another question here. This is a different subject and kind of a head scratcher for me, but with respect to the ADA, who is defining quote unquote reasonable in terms of reasonable accommodations and accessibility?
Well, I know in our community we do have an ADA liaison for the county, and she's very helpful. You know, it's really a community standard. I don't think there's any particular bright line, but sometimes these things are just so, you know, outrageously not reasonable that it then goes to the court. But I don't think there's any bright line. It's what you know, within that community would seem to be and you know, the situation would it's kind of like what the Supreme Court justice said. He couldn't define pornography, but he knew it when he saw it, and I guess that's kind of what reasonable is, you know, but sort of in the eye of the beholder.
Wonderful. And one last question here about the Ashley case, and they were wondering what the final outcome was of that case.
Well, they did go before an ethics board, and they were granted that they were given the okay, and she did undergo the surgery, and she has been given the hormones, and that's but it raised, you know, a lot of questions and discussion. But they did prevail. The parents did prevail.
It's definitely a case that I think will show up in a lot of ethics discussions for a long time, I think.
I think it's something, if you have an interest, if you just Google the Ashley treatment, there's a lot of information, and there's been a lot of literature, you know, and comments and perspectives that have been published regarding the ethics of that case, and a lot of the disability associations that certainly have taken position statements about the Ashley case, and why the reasons of why there is a objection to some of the rationales that were used to describe and to undergo that treatment for that young girl.
Right, and it really kind of points out the sort of balancing the needs and desires of the caregiver versus understanding what the quality of life for that individual might be by changing her, you know, her entire development. So it's interesting. As Liz says, there are a lot of different viewpoints, and it's interesting to consider them.
Wonderful. Well, thank you very much for that explanation, and I would like to thank you, Dr. Perkins and Dr. Woodard, for a great webinar tonight, a great presentation. I would like to thank all of you for attending tonight's installment of our webinar series. Please remember that in order to get your CME certificate, you need to go to the website on your screen. We will have a PDF version of this presentation and also the PowerPoint version available as well for you to download on that same site. So
Matt,
please join.
Could
yes.
I just interject? There is on the PDFs and on the PowerPoint, we did have a list of a page of resources that have live links, and those live links should work from both the PowerPoint and the PDF of the handouts, and so we do encourage individuals to access those websites. And we would really would like to request that individuals watch there's a short video called A Credo for Support, and which I think is a very impactful video that I think that is a useful introduction about the whole notion of advocacy and how individuals with disabilities, how they want to be perceived and not what we think is important. And I think it's a really good educational tool, not just for physicians, but people within your practice and other medical professionals and healthcare providers, just to take a look at that. Would you agree, Dr. Wood?
It's very powerful.
So please have a look out for that.
All right, great. And also, please remember to join us next Tuesday at 6 o'clock Eastern Time, when we'll be discussing the common characteristics of neurodevelopmental disorders and the 6 most common diagnoses that you'll see in this field. So thank you from all of us at AADMD, and thank you, Dr. Woodard, thank you, Dr. Perkins, and all have a good night.
Thank you.